everything's going fine. Can you see the audience? Who we've got? I'll just show you around. There's a couple that you may know. We've got Saad on the front row. Jane sat next to her. Janet sat next to her. And Sajda, she's the lady who organises an awful lot of the course.
Hi.
The person panning the camera, who's camera shy, is Sharia, and he avoids everybody. But this chap you may know, because he worked with us in Kingsmill for a while. Hi.
Hello.
Excellent. Now, Jane, I've let the guys know that that your role within our hospital is very, very demanding and covers a broad spectrum of things, including education, associate dean, a lot of things. And one of the subjects that I think that is very important is about, we've talked about it, is decision making. And decision making at a senior level and how to actually facilitate that within our juniors is often something that we assume happens. So could I ask you just really to chat about how you perceive decision making at a senior level is perceived?
Sorry, I didn't catch bit of that point. Is perceived.
As perceived or acted upon or encouraged within our juniors. How do we actually demonstrate it?
Thanks, Paul. I think it's important to distinguish between clinical decision making, what I would call professional judgment, which enables us to make decisions in the complex working environment that we now have. I'm talking about the UK, but I suspect it's the same in Pakistan. So what do you mean by that? We live in a society with an increasingly elderly population, with rising expectations about what can be done in terms of healthcare. We have technological advances, but we have financial constraints, and it's a matter of what is the right thing to do. We have more accessibility in terms of the general public, in terms of our adults, and we have to try and work out what's the right thing to do in terms of what the patient wants and whether that's realistic expectation. I guess, bearing in mind you're gathered on an endoscopy course, what I want to say is, who do we think we are? Are we technicians just, or are we specialists? And I would want to encourage us to think of ourselves as specialists. And it involves decision making that isn't just about being within guidelines, for example, although they are.
Excellent. Jane, the thing that you were saying early on, where we've got an increasing elderly population with increasing expectations. Over here in Pakistan, there's a lot of people who are grateful for what happens within the setting that I'm here at the moment. Just really from our point of view, do you think that there was some time in the UK where people just accepted what was done for them? And what do you think actually caused that change?
Yeah, I agree. I think there was a time. I think that's probably 1 or 2 generations ago, where perhaps before the National Health Service came being, and then it arrived in 1948, free at the point of delivery or at the point of need, and people were great treatment available. I think we've become used to that, and we've separated financing for that from how we use that and whether we use it responsibly or perhaps less so. So I think successive governments have built an expectation in society of what is available. Now, the message that the government wishes to get across, the sort of headline, is not necessarily what's understood by the population. So this mismatch between what we can deliver and people's expectation. So take, for example, the elderly. I think there's some difficult decisions to be made about whether our interventions are actually going to prolong people's life, whether that's the right thing to do, or whether our interventions are going to increase the quality of somebody's life.
Do you feel, Jane, that sometimes we're caught in a bit of a difficult scenario where people are sometimes making the decision not in the best interests of the patient, but in the best interests of what suits the clinician that was involved at the time?
I think that's a really good point. I think we need to be aware that our own personality, our own ethical or moral framework, our own worldview and forms of decision making, and that may be conscious or unconscious. Just to give you another general, how life and death, I think, reflects in our decision making. If we regard the end of human life as failure, we strive inappropriately to keep people alive who would naturally die, because that's how we view death.
Jane, I think that's a very relevant point. Saad, have you got anything you'd like to say?
No, I think the point that she's making about...
Can you hear, Jane? Can you hear what's that?
Just about.
Jane, no, I think the point that you made about the population age changing, the needs of the healthcare and the cost of healthcare, everything changing. Obviously, it's making very difficult at the delivery, sort of place. I mean, it's very difficult to cope up with the advancing age, increasing cost, and one has to be more sensible. Like you just said, quite often you're just trying to prolong life, and that is a very difficult decision. Sometimes even here, we have we have a mixed population here. And cost becomes very, very important here because the patient, we don't have a national health service, unfortunately. So everybody ends up paying or utilizing the government services, which obviously in most cases are not what they should be. So, cost end of the day becomes important, but you have to be realistic with medical services that we provide. At times you see decisions that have been made on people who are either put on ventilators or actually are, from our course point of view, are undergoing colonoscopies for things, even if they were to find, we know they were not surgically fit. So end of the day,
Yeah.
you know, you'd say, well, what are we trying to do? You know, at 85, 90, do we really want to continue? Does the patient wants to continue? Does he have the quality of life that he deserves? Or does he really want to? Because quite often we are not giving them full information. So I think it's very, very important in today's world to be very, very sensible with resource utilization in every sense of the word.
Jane, can I just ask, it's not trying to be personal or anything, but at what time in your career, and I'm not trying to expose your age by any description, but at what time in your career do you feel that you were able to start to consciously and thoughtfully and appropriately make the most considered choice direction for the patients within your care?
Thank you, Paul. I think it's a gradual process. I can think when I was training of one or two consultants who were really exceptional people in terms of their clinical judgment. And I saw that, and I had the opportunity to discuss why they made certain decisions in certain situations. And then I think that it's been really a gradual process. I think being in the same place in a career post as a consultant allowed the outworking of the decisions that you make. In a sense, you live with your decisions, and I think that informs your subsequent decision making. I think I think it does happen gradually. I think as we gain experience beyond what we learn in text, for example, and understand the natural history, the natural progression of disease processes, and the effect our intervention make. And basically, that's how it happens. And as we reflect on that, it sort of informs our next set of decisions. To give you an example, using adjuvant chemotherapy in people with gastric cancer, I realised that their life expectancy was on average prolonged by the length of time for which they actually had the chemotherapy. So they might be longer, but they didn't have longer, what you might call hospital-free survival. So what did they gain? And that enabled them to have a conversation with other patients about what are they set on surviving, if possible, to a target date, be that child's wedding, birth of a grandchild, and they're prepared to accept whatever we put through, try and reach that date. Or do they want to have free time to do whatever they want to do while they're well to do that? That's just one example.
Jane, I've got two small questions left. One, is that you talk about discussion an awful lot with the patient. You talk about
Yeah.
involving the patient with that decision, and that you're not just looking at a set of case notes in front of you, a set of results in front of you,
Yes.
and making a value judgment that and steering that patient in a direction. Would you say that is the right way to go forward, the best way to go forward, or would you say that just to make a didactic, prescriptive decision and just tell the patient this is what you're going to do?
Absolutely, Paul. It's really important that we understand the patient's perspective, and sometimes, in fact, often helpful for somebody else to have been involved in that discussion with the patient as well. You know that we discuss GI interventions. You yourself are specialist, are nutrition specialist nurse, and I find discussions really helpful. It's good to have more than one perspective.
Absolutely.
I guess that's the basis of multidisciplinary team working, but it's absolutely essential in that somebody takes the responsibility for knowing the patient well and understanding their perspective, rather than just making a decision based on what the guidelines are or what the evidence base is.
Excellent. Jane, we're coming close to the end of this chat. I'm going to just ask for a couple of the audience if they've got any questions. I'd like to say thank you at this point, because you've been very, very honest, very, very open. It's very rare sometimes that we see people in very senior positions who are willing to share this part of the role and the job that they see it. And often I think it's very important that we see that. And I think this is a very honest approach. So could I ask anybody in the audience, have they got any questions to ask Miss Patterson? Don't feel shy. My American friend. Yeah.
Hello.
Hello.
I just needed to ask, in perspective of this training that you are doing here, as an example for colonoscopy, where does decision making end and where does consent start? We are discussing the options with the patient. We are the ones who are telling them when to go for an endoscopy and when not to go for an endoscopy. And then we explain what happens when we are doing the endoscopy. At what points is decision making important on the physician's part?
Paul, could you
No
just
worries.
repeat that? 'Cause I didn't catch yours.
Jane, what she's actually asking is as part of where does the decision making start or end? Is it with the consent or is it with the colonoscopy itself? Is that what you're asking?
Oh, well, I think decision making, in the sense, doesn't end. I think assessment of the patient and their symptoms and their gentleness and what their expectations are as far as the test is concerned happen before you think about taking consent. And then consent is not just signing a form, as we know. It's a process that involves discussion of the relevant risks and benefits for the patient. And then, given the example of endoscopy, I think we make judgments both before and during doing the test about what the right thing to do. So I guess in answer to your question, it's a continuous or semi-continuous process.
Would you
I hope
suggest
that's helpful.
that is, Jane? Would you suggest that the decision making is before the consent, the decision making is influenced by the consent, the actual procedure then either confirms the decision was actually the correct one, but that then starts a further decision making process. So the decision making never stops; it just presents alternatives
Yes.
as we go along.
Yes. It's a series of steps. Yes.
Is there anybody else?
I think the other thing I would want to add at this point is I would urge to be more intentional about how we model our decision making to those we're training, because I think we sometimes make unvalid assumptions that they are observing this and understanding what is happening. And I'm not sure that that's always the case.
That's a very good point.
I think that's probably the most relevant point that these people could take home, and I think talking about being the correct role models, having the correct intentions, that is I think the best take-home message. Has anybody else got a question? No? That's it? No? Jane, I'd like to thank you very much for your time. Nice curtains, Jane. Absolutely lovely. So, and I'll contact you later, Jane, and hope things are going okay with you, especially with Liverpool, and thinking of you from this side.
Okay, thanks very much.
You look after
Have
yourself.
a good day.
We will. Thank you, Jane.
Relevant to not just doing procedure that you are here for, but also what we do in our regular daily, day-to-day medical life or professional life. It's about when you make a decision, how do you come to that decision? As a senior, when you're making that decision, it is my responsibility to actually teach you, tell you why I chose this, rather than, for example, if I want to decide that I'm going to give palliation to a person, rather than going in for active surgery or active treatment or whatever. But the last point I think she made was very important, that because you're going to become senior very, very soon, is that when I'm taking that decision, I make the decision and I assume you understood why I did it. If I don't sit down with you and explain to you, yeah, look, these are the pros, cons and all that, this is something that we don't do as trainers. So I think that is something that came out in clear that we should actually share it with you and we should discuss. I always encourage discussion and questioning. Unfortunately, in our system, in our culture, questioning is not taken as something that is it's acceptable by the boss.
Like opposing something.
It's like opposing somebody when you question. Yeah, it's literally that. So that is why you see when they start, the first day they are reluctant, the second day they are a little bit more interactive, the third day by the time they relax, the course is over. I think that is one of the big problems. But the ecosystem did not change overnight there.
That's why I asked you to talk about
the consultant there was untouchable when I went. And I'm not talking about 100 years ago. 1989. God.
1982, I would walk down the corridor and a consultant's walking towards you and expect to stand back by the wall as you walk by. Stuff. But that's what was expected.
So, it changed and questioning. If you think that is not correct, then the only way it's going to change is if you change it. But when you become a consultant, you follow the same, then it's never going to change.
So the first thing is that we should think like that.
Some of the things that we're doing here are not related to just talks and push advance or whatever. You see, it's about general concept. So the discussion here was about decision making. How do you come to it? Do you always decide yourself? You're not sure. You ask a senior. Call a friend, call a colleague, and say, "Yeah, this is what's happening. What should I do? I'm not sure." especially if it's something that's related to something very serious. And so it's general, if you want to say professional way. Okay? It's not about a procedure, a technique, a specialty. It's a general thing. If you are compassionate towards your patient, you care for your patient.
And during the decision-making process, you involve people and you go for multidisciplinary approach. You ask other colleagues and you.
I'll give you an example where I rely on my juniors. I'm totally reliant on my juniors. You know, I have this young females, young girls, if I can say, 16 to 20. They come in with vomiting. For the last 6 months, no significant weight loss, normal endoscopy. And they just keep on taking. What do you do every day when she eats, she throws up. Tests are normal, you go and you do a barium follow-through, you find that it's swallowed. Maintain that, they have no issues. I will go down to my house officer or SHO or a junior lady and I will tell her, can you sit down with this girl and talk to her and find out what's going on? There's something going on, this is not organic. And she's not going to talk to me, that girl. She's not going to trust me. But if one of you were to go, especially the younger, the better, because they obviously feel closer. They go and they come back, sir, there is a problem. She wanted to go to college, she has been stopped. She wanted to do this, there is some family issues. Mom and dad have some serious issues. And the penny drops. Okay, so when you say you need to involve people, it's for a senior person, it's very important not to undermine, not to pay attention to what your juniors are sometimes saying. Obviously, some juniors are, over a period of time, you realize that you don't want to pay any attention to what they're saying because they're not interested or they are not making sense. And you give them a couple of chances, third chance, and you realize, okay, fine, I don't want to waste my time unless you want to teach them, and some of them don't want to learn. So, you just stop. But you need to involve people. And if you start that practice today, जब आप senior होंगे, so then you will be able to utilize it and actually change things. Change it better than what you think you have at the moment. Because I don't know how many of you can actually stand up to your professor and say, I'm sorry, why did you do this? Why are you using IV Isaac when it is not indicated at all? You can't. I know that. But what you can do is I tell my cleaner, I say, yeah, why can't you? When I see the notes, I say, what is this? I said, oh, this. Ex-consultants. If you not ask them, I was just reading, I'm not sure there was a confusion whether we can or can't use this in a acute situation. What is your view? So you are making him think and then answer, and if he gives you a reasonable answer, fine. If he doesn't, then you know that he's talking rubbish, so you do what he tells you to do at that time, but you know that's not correct, so in your own practice. So basically, bottom line is decision making के लिए you need to have information. If you're not well informed, you can't make a decision. So get information from colleagues, from trials, from whatever sources you use to study, to get that information and then make it.
That's why I recommend it.
So that was on a lighter note. We had enough. There's a couple of things that Vakar highlighted, and I've said it before. A few of you were not there, and I'm sure my colleagues would second me in that. You started about decision making, so when you're deciding that you need a colonoscopy, 25-year-old young male comes in with on and off stool issues, abdominal pain, liquefaction, some pain, no weight loss, no blood in stool, absolutely fine otherwise, sometimes under stress gets the symptoms. Do you need a colonoscopy? Yes, you do. In Pakistan. Everybody gets it. But no, you don't. This is a patient that you would not. Okay. So I'm just giving examples of decision making. You need to follow the guidelines that you are quoting, you're reading, etc., and you all know about it. After that, you come to the information to the patient, which is very important. You keep your contact with the patient from the time you see the patient. That's very important. Trust me, in your private practice, that's going to help you the most. Then you come to patient's dignity. It's very important that whenever you're doing a colonoscopy, your patient is completely covered as much as possible. Once you've got the scope, you can put the sheet, you don't really need to see. I don't. My patients, you don't have to have them exposed, and I'm sure they do. So make sure that your patient is not exposed. When you're doing a PR, just don't go and say, oh, patient is ready, okay, fine, but sir, what is this? Think about what you're feeling. Don't do that, please. Especially if you've attended this course. Next time when you go and do a rectal examination before you put a scope in, just tell the patient, I'm going to examine your back passage. It will be a little uncomfortable. It is a little uncomfortable feeling unless you have.
Another thing is, don't expose the patient and don't hold the scope for right, because when you hold the scope there, the whole bump comes up on the screen, and I think that is very degrading.
Achha, and I don't know in your unit you do that or not, but my patient can see what I'm doing. They're actually watching as I'm doing endoscopy. So when you're putting your camera on the bump, they're also seeing the bump, which is not a
So
good
it
thing.
is really degrading, and in fact in UK, our patients wear dignity pants, which are like underwear, but with a slit in it, so that they are fully covered. So I think everywhere one should respect dignity, especially if you are examining female patients. And it is of paramount importance that they don't feel exposed or vulnerable at any stage. Because you are in a position where the patient will feel very vulnerable to you. So don't make them feel like that.
She's a vulnerable woman.
Okay? So, contact with the patient, decision making, contact with the patient, explanation, reason why you're doing, consenting we discussed, technique, covering, having a female, and you have a female, these things should be really absolutely mandatory. There is no reason for not having it. When you're doing it, this has to be. Just because somebody is poor, because she doesn't have a choice, or he doesn't have a choice, doesn't mean I have to. And I'll tell you, from my point of view, there will be questioning of it. So you may get away here, but there is no getting away of it. We as doctors, it's a double-edged sword. It will cut the sins, but it will get you, if it's the other way around, it also cuts your neck. So those are the things that we wanted to highlight now. From now on, we've got 5 and 7, 12 more cases. Sajda, am I right? Yeah, till the course finishes. We've got 12 more cases. For the hands-on people, we want you to go in and, before we do the actual procedure, make note of what we have suggested and make sure that you practice from here on. That the next case is for you, literally your real case, and that's how you should practice when you go from here. And it will make us all very happy and proud. Okay?
We always say this to our candidates that please feel free to get in touch with us even when you left this course. We are available for advice, for any updates, anything you want to discuss. We give you our email addresses, our phone numbers. Please feel free to contact us at any time. Secondly, as we've always been saying that you do not expect to become masters in colonoscopies after this course. Make a note of what we discussed with you, what weaknesses we highlight, and try to practice on them at home. You can't get it right in one day, in 1 month. It might take ages to get it right, but please work on that. Secondly, if you feel that you need to learn colonoscopy well, you need to do it well, and you are in a job where you only get to do 1 a week or 2 a week, that's not enough. You need to be doing it on a fairly regular basis so that you become, special. Even if I'm not doing, more than 150 a year, they are me to stop doing it. So I've been doing it for over 25 years. So if you need to learn, make sure you are in the right job and do something. Because if it's not something which is DIY, you do it yourself or teach yourself, it has to be supervised where it's your safety.
In this area, the colon cases are less as compared to the western part.
No, it's not that.
I can
No, okay, just the right, coming to the right people. Obviously, they won't be coming to you directly, but if you are in the right sort of centers, you do a lot of colonoscopy. I mean, in this center, they do far more than we do in England. The number of colonoscopies done by Dr. Shah's unit are far more than what we do. So it's not a question of, it's the question of working in the right place. You have to come into find the right job.
Okay, just some housekeeping issues. We have 5 colons left.
Right.
We'll do 2 more before lunch.
Okay.
So 2 candidates will have their, then we'll have 3 more left
Okay.
after lunch, which means we'll wind up obviously early. I have to do a pseudocyst and I have to do an ERC. Okay? So we have 2 options here. One is, and you all can decide because this is not something that we have done before. I have another room, so I can quietly continue and finish that while you people are doing. The other option is that once we have done all the colonoscopy cases, we then can transmit those 2 cases.
I think that will be better, Sir.
You want to see?
Yeah, yes.
Are you sure?
That must be better.
Really? Okay.
Yeah, I think it will be better that way. It will be good for them. entertainment.
Okay, if time permits, if it's getting late, then I will continue doing and you guys can move. No problem.
Yeah.
ठीक, done. Sajda, sorry. शहरियार, ठीक है? क्या ख्याल? जल्दी खत्म हो जाएगा। ठीक है, तो आप ऐसा करें 2 केसेस तो अभी करा दें।
Just tell us the brief history before starting the colonoscopy.
No, we won't tell you anything. I'll just go in straight. I'm just joking.
The cases that we are seeing.
Oh, the colonoscopy. No, actually, oh, sorry. You're not telling.
No, we haven't heard anything.
Colonoscopy की case तो बताएं why we are doing it.
Why you are doing?
But the indication that they are
I'm so sorry. Then that's a very big.
I
Sorry,
think we know what to
Sharia.
say, but we are not on the.
We all get, they by the time they bring the camera, I think उनसे क्या है शहरियार?
No, I'm going to have it.
Yeah, please just briefly, not the whole history about diabetes and non है या नहीं.
Colonoscopy was performed, which showed proctitis and single sessile polyp at sigmoid colon. For that, EMR was done, and the biopsy showed chronic active colitis. So now he came up for follow-up colonoscopy.
As far as the
Polyp showed chronic active colitis.
So the polyp is just an inflammatory polyp?
Yes.
he's saying he's showing the giving the history of the bloody diarrhea, not the bleeding PR. The blood is mixed with the stool.
Yes.
And his first colonoscopy was done in 2013.
2012.
He's saying 2000, and then someone, a consultant, started the ESA-call, and he's coming back
His
for
previous
the.
colonoscopy was performed in the same unit,
yeah.
so he came up for follow-up.
Yeah,
colonoscopy.
because of the dropping of the hemoglobin. Yeah.
ठीक है वो
Communicated to me on Friday morning, and I said, the consultant actually called me to coordinate. He was trying to get the couldn't name the consultant, the office guy, the office. Oh, which is.
That's one big watch. That's a big watch.
Smartwatch. Smartwatch. You can call.
Can you?
Yeah. Call, and this is not charged. You can call. You can receive.
Phone calls
Yeah, phone call.
to the watch.
Yeah. This is a smartwatch I just purchased from Dubai.
Not.
Korean. The same here. You can charge
We'll
from
be with you in
here.
a minute.
You can charge from here. खोलिएगा यहाँ से.
Ah.
You can place the SIM.
Ah. And how much is that?
This is a smartwatch. Nowadays the watches are coming. खोलिएगा जरा से.
आपने ग्लास पहने हो आपसे नहीं निकलेगा सर आप ही खोलो लेकिन गिरेगा नीचे
So this is a phone.
Yeah, you can call, you can receive everything. The SIM and
Oh, that's good.
How much?
Pakistani 14,000.
That's not too
$14.
bad. No, 14,000. 14,000 rupees, yeah?
Yeah.
So 15,000 is £500.
Yeah. 100 pounds is
Three. So 3 into the, call it 15. 3 into that is 5. So 520, £20 gives you 3,000 rupees. So you don't trust us to look after your watch now, do you?
No problem.
No. We don't swim. Probably don't know what I'm saying. We don't swim.
बड़ा सांस में ढीला छोड़ें, टाइट ना करें इसको पैर
And is that SIM free? As in, can take any SIM?
Yeah.
ढीला रखिएगा भैया, टाइट नहीं करें।
ढीला रखें, ढीला रखें। If there is any abnormality on the side, we have to see start
We'll do at the end.
at the end.
Yeah.
ढीला छोड़ें भैया।
ठीक है।
Just pull that back so it's in a straight line. Keep this in. That's good. Excellent. Keep hold of your scope. It's going to come out. Good. Well done. Now, with this is quite, how would you describe it? Is this severe? Is this moderate? Is it mild?
It is moderate.
Moderate? Okay. I would actually say this is probably bordering on severe. We've got a few little ulcers.
Yeah, it may be a moderate.
Granular, complete loss of vascularity. It's bleeding spontaneously.
Yeah.
So does that change your view of it in any way? Does that change your view from you saying moderate? I would say bordering on more severe than moderate. What's the definition of moderate proctitis?
When there is inflammation and the little mucosa is normal.
That mucosa is not normal.
Some of the mucosa.
Where's the vascular pattern?
So, vascular pattern is there.
Where?
In
Show
the
me.
top.
Pull back. Where? Clean your lens. That's scarring, the white area scar. Where's the vascular pattern? So are we still moderate?
Severe.
Severe. Okay. So when you've got severe, border on severe, we're looking at a potential for friable mucosa. And if it's friable, it could be what?
Perforant.
Tear, yeah. Okay? Nice and steady. So we're trying to keep the scope as straight as possible. Brilliant. So where's the lumen?
On the left side.
Excellent.
So how are you going to turn to the left? Okay, this will help you. Slowly, keep your shoulders square. Don't have to, no, keep your shoulders square. Straighten your arm. Just straighten it. Just straighten it. Trust the arm. Too much. You don't need to go, okay, you just need to do slow. Okay, that's good. Anti-clockwise. Excellent. Excellent. Well done. More. 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 Brilliant. Stop. Now where's the lumen? 12 o'clock. Okay? So how are you going to make it look up? How are you going to make it look up? That's it. Well done. Well done. Now, can you see vascular pattern now?
Normal.
Normal. Few aphthous ulcers just there. That's great. Okay? Advance. Advance. So get your head up. So get the nose up. Get the nose up. Up. That's good. Small aphthous ulcer there. That could be the bowel prep. Okay? Up. Advance. Let the clockwise torque slowly come in. Let the clockwise torque. Don't have to draw back. You just let the torque return. Let it return. Let the torque return. That's it. The clockwise torque return. It's good. Now neutralise your scope. No, you don't need to do that yet. Just draw the scope back a centimetre. Draw it back a little bit more and a bit more clockwise. Don't need that. Doing this does nothing. It's this or this. This. Okay? Or that. Okay? Okay? That's better. Clockwise torque. More. That's it. And get your nose up. More. Brilliant. 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 Excellent. Keep going. Excellent. Nose up. Nose up. Nose up. Big wheel back. Keep going in. Nose up. Well done. Now, what you've got to be careful of is that you're going to be tempted to keep clockwise. And you're going to end up putting the loop outside there, which is going to cause this, which is going to cause this to loop on itself. Okay? You're going to keep hold of the scope. I'm just going to show you what to do. You look at the screen. You're going to keep hold of the scope. So slowly and adjust your wheels. Keep them going. Slowly and adjust your wheels. Hand over. Great. Let the wheels go. Just relax. Good. Open your stance. You're actually crowding the scope. Okay. Now, draw it back now in a straight line. Draw it back slowly. Now you can see where you want to be. Draw it back just another fraction. Now where's the lumen? Shiny? Darker? Come back just a little more. See where the lumen is now?
Yeah.
Okay. And is that easier to control? Just stop where you are. Don't move. No, you're moving. Don't move. Okay? Anti-clockwise again. There. Now, big wheel back. So look up. Look up. Look up. Look up. Look up. Look up. Excellent. Okay. What we're trying to do is keep the scope as straight as we can, as early on as we can, okay? Good man. Where's the lumen? Where's the lumen?
Center.
That's centre. Is the lumen going this direction? So 12 o'clock, 3 o'clock, 6,
3 o'clock.
3 o'clock. Excellent. So how can we make sure that we can get round that? Where is the ideal position for it to be? Where would we like that lumen in relation to 12 o'clock, 3 o'clock, 6, 9?
6 o'clock.
Okay. Do you remember yesterday when we put the scope in, we pulled the big wheel back and it lifted up? Do you remember what the scope did? Do you remember how the scope could do this? So ideally, where would we like the lumen?
On the top.
Telling me or asking me? Telling me or asking me?
Tell me.
That's right, put it at the top there.
But what about if you just keep it at 3 o'clock, give a slight clockwise top?
You and I would do that. Right.
Pain or everything.
So why is it not going through?
Only a loop formation.
Ignore that. That's just dancing. It's snake charming at this present moment in time. So why is it not going through? Okay, stop where you are. Is it feeling, when you slide the scope in and out, is it hard? Is it easy?
Hard.
Hard. So, have we got enough gel on the scope? Let's rule things out, what it could be. First of all, rule out, is it gel on the scope? How's it now?
No. Comfortable.
Comfortable?
Easy.
Who's bottom?
Then previous.
Easier than previous, that's fine. So, go forward, slowly apply, clockwise torque, slowly apply. That's it. What are you doing now? Stop. What you do is this, stop, freeze. What you do is this, you do something, and then you do this. Then you do some, and then you do this. Don't, okay? You want to commit to the torque. Now, slowly draw the big wheel back. There. There. See? What's he saying?
Feeling pain.
Tip up. Get it into the centre. Now suck a little bit. Suck. Tip up and back, because I know that's what you've done. Suck. Suck. Right, stop. Is that better?
Better, okay?
Yeah. Because I know that you sat on the blow button. Do you know what that means, sitting on the blow button?
Sitting on.
Yeah, sitting on the blow doesn't mean you've been in a jacuzzi. I've got a jacuzzi. Well, we've got a jacuzzi. My wife's got a jacuzzi. What? Stop. Stop. Where's the lumen? Okay, so how are we going to make that work? No, stop. How are we going to make that? How are we going to progress?
Come and keep the lumen on the top.
And how can we keep the lumen on the top?
By moving.
Right, so the lumen's going off this direction. Okay? So we have got a chap. We have got options available to us.
Change the position.
That's one option. The next option is he's got pain. because you put insufflation in. What you could do is just advance and slowly turn into it, pull the big wheel back and see what happens. And stop. We're talking about what our options are. The other option is bring him onto his back, and because we bring him onto his back, that will come to the top, because it's equivalent to putting 90 degrees of clockwise torque. That would allow the air to spread across. So if it was you, which one would you prefer? Continue to advance?
We'll change the position.
Change position. Why?
It will make difference. That will be more easier.
In what way?
The lumen will be more exposed.
Okay. So you're saying that turning him onto his back will actually open that up.
Yeah.
But what about the air? What will it help with the air? Because you've put a lot of air in, so what does it do to the air?
Check the abdomen.
No, it spreads it out. It no longer goes to the high point, which is here, goes to spreads across. So come on to your back, my friend. Hold your scope. Hold your scope. Keep your eye on the screen. You focus on the screen. What's she saying? Draw the scope back. Bit more. Now go forward. Good. Good. No, you've got to commit to it. So go forward, clockwise torque. See? You've got to commit to it. Keep going forwards and backwards, you'll spend there all day. Okay? You'll be there, you're just going like this, you're going like this, you're going like this. You'll never, you've got to commit to the actual bend. Don't suck. Okay? Draw the scope back a centimetre. Get your view. Get your view. So, there you go. Where's your view? Yeah? So if you advance your scope, let the anti-clockwise come in, big wheel back, clockwise torque. Happy?
Yeah.
Get your nose up, suck, suck, stop, draw back, go forward. How does that feel? How does that feel?
Good.
Okay.
Yeah. Better than previous.
Ah. It's hard when we first work together because we've got to get over the language barrier. My mate Eric now is substituting. But this time you understand what I'm asking. Okay? Pause. Pause. Excellent. Nope. Pause. That means don't move. Even if you've got an itch on your nose, don't scratch it. Okay? Clockwise torque. Go on. Clockwise torque. Stop. Big wheel back. Stop. Bit further. Bit further with the torque. Now, draw back. See. Let the anti-clockwise come in. Just a little bit. Suck. Too much. Up. Up again. No advance. Leave the scope. Big wheel back to get your nose up. Up. Clockwise torque. Draw back. Go forward. Go on. You've got the scope. Go forward. Go on. In a straight line. Go on. Keep going. Keep going. Okay. Now, have we got enough gel on the scope? It's a question. Are you finding it hard to put the scope in?
Yeah.
Okay. The last time you found, I've got hold of the scope to stop you doing things. So the last time you found it hard to go in, what was the problem? Not enough gel on the scope.
Yeah.
So the last time you couldn't advance. So what do you need to do?
Come back.
That'll put gel on the scope.
Yeah.
Okay. Away you go. Go on. You've got the scope. Hold the scope about here. Hold the scope about here. There you go. Advance. There you go. Excellent. Excellent. Go on. Nice and slow. Get your nose up. Go on. Sometimes when you come to this area, which is the splenic flexure, you do need to put a little bit more scope in. So just put slowly advance, slowly advance. Keep going. Slowly advance. Keep that on. Keep the torque on and just slowly advance. Keep the view and slowly advance. Go on. Okay. Now, keep it going. Just a little bit more. And now anti-clockwise. Anti. And now get that tip in the centre, big wheel back, and draw the scope back. Take your finger off the blow. Take your finger off the blow. You've put too much air in. That's what his problem is. You put too much air in. Big wheel back. Take it back. And now go forward. Was that better when we took the air down? That was a little bit tense just there. What's he say? Okay. Let me just take this air down for you, my friend. Let me just show you. And you can have it back in 2 seconds. Okay? Let me just take the air down. Is that better? What's he say? Is he after you? Okay. Clean your lens. Straight. No more air. Watch where the lumen's going. Excellent. Watch where the lumen's going. Yes. See the folds? They're like steps in a ladder. Yeah? Get you in. Oh, come on. Keep going. Don't suck. I switched your air off because you keep blowing. You rest your finger on the blue button, so I switched it off. Yeah. So if you keep resting it on, I'll switch it off again. Keep going. Nice and slow. Go on. Nice and slow. Take your eyes off this image. So what? Pause. Put the scope down. Okay? Do. What are our options?
Suck.
Okay, if we suck, the suction port is here and we grab this tissue. Okay? So what are our other options? At the moment you're doing this and you're not actually either going forward, you're not actually coming back. Okay? Yes, if we cause discomfort, we need to stop. But we also need to commit a little bit more to the actual process of going forward. So have one more go. Just slowly intubate the scope. Did you see the scope stay still? So draw the scope back now, keeping the view central, and then just advance a little bit. So keep the scope central. Excellent. Draw back, and now go forward. All those bubbles are telling me you're blowing. All those bubbles are telling me you're blowing. Okay? Yeah. Go forward nice and slowly. Get away from the go down the centre of the road. Okay?
Can you change the position here?
What position would you like him in, and why?
Because the scope is not going, I will.
Okay, let me show you something. Okay, the scope, right, is here. The scope will go forward, okay, just a little bit. But what you need to do with the scope is keep your lumen in view. If we actually pulled it back with the right torque, you'll see that the lumen will come forward. I'm cleaning the lens. See? Now if we keep that torque on the scope, keep that torque on the scope. Okay, that. You will go forward. It's over there. Good man. Clockwise torque. It is clockwise torque, my friend. Excellent. Now you need that hand slightly closer, so you need it here. Okay? Well done. Keep going. Excellent. Keep going. Better. Clean your lens.
Lens come sharp.
Take your finger off the blow. That's it. Good man. Keep going.
जाने देखें ऊपर करें. Yes.
Yes. Keep going.
अभी भी लाइट आपकी 5
Ignore that. Tell you what, I'll switch it off if you keep looking at it. Clear.
लाइट आपकी 5 o'clock पे. इसको सब ऊपर लेके सब नहीं करें.
Keep going.
Right 5 o'clock.
Keep going. Go on. Advance. Steer.
जी जी.
That's it. Advance. What's he say?
Pain is
Your finger is just touching the blow, my friend.
left side.
Eve-
Left side pain.
Okay. Let's put you back up onto your left then. Come back up onto your left. Hold your scope. Don't let your scope come back.
करवट लेगा तो
Keep your view. Keep your view. Keep your view.
ऊपर नहीं जाए. ऊपर नहीं जाए. नीचे है नीचे. और नीचे. ठीक.
Now, what should you do once you've moved the patient?
Gel.
Gel? I always thought it was draw back. Draw back. Draw back. Draw back. Draw back. Clockwise torque. Draw back. Draw back. Clockwise torque.
इसको छोड़ दें. उधर देखें.
Keep coming. Clockwise torque. Head up. Nose up. Suck. That's enough. Draw back. Now go forward. Draw back and then go forward. Stop. Let's just put this. Hold your scope. Hold your scope.
Yeah. Just a
Now, draw back the scope, keeping the centre. That's it. Keep it to the centre. Suck. Just have a little look. What you're getting stuck in is you need to get the tip central to the lumen. If you remember, I said we put the stiffness on and I draw back the scope. Okay, see how far we've drawn back the scope before you can go forward with the scope. Okay, so as you go forward with it, if you don't come back far enough, you will not go forward. Take the stiffness off, and now let the scope sit there. Okay. You're not coming back far enough with the scope when you reduce. That's good. Keep it going. Keep your centre in the view. What you're doing is that because you're hitting the folds, it's making the scope buckle here. Do you know what I'm saying? Because the tip is hitting the folds, it's causing the scope to buckle. Keep the tip in the centre. Right, tip up, suck, tip up, now suck. More, enough. Lower a little, draw back a centimetre, another, now go forward. Go forward. Go on. Excellent. Now stop. What we've got is a little bit of a loop here. Okay. Straighten your legs for me, my friend. Straighten your legs. Just roll that way a fraction. That's enough. Draw back. Keep it coming. Keep it coming. Keep it coming. Now go forward. Get your hand closer. Get your hand closer. Good.
कम से कम 6 इंच डॉक्टर साहब को जो है ना पीछे से पकड़ना होता है 6 इंच का फर्क होना होता है.
Good. Keep going, my friend. Excellent. Keep going. And this prep ain't going to tell us a great deal, is it? A few inflammatory areas just here. Keep going. Right. Just stop. The only thing that I'm concerned about, because we're getting this effect, where we go? Here, and because we've got proctitis, okay, I get concerned that we're going to cause some damage in the rectum or local to it. That's why I get a little bit precious about it. If we were not so problematic down there, so inflamed, I wouldn't be too bothered about a little bit of indentation. Okay? All that is that I'm trying to clear the lens. Okay? Come back, go forward. See this? Come back, go forward. Come back, go forward. Yeah? See? Come back. See how far we're coming back? Suck on down. A lot of air in there. Can you see that air? And that collapses down. He should feel better now. Does he feel better, Eric?
अच्छा अभी दर्द में कमी हुई है
ठीक है बेटर अभी तो नहीं हो रहा.
So come back. See the air? How much there is? Come back a little further. Go forward. Okay. Now he's moving his feet. Get concerned. If we look at that, we can see this effect again. But if we haven't got anywhere to put it, now you see here what I've done. I've transferred a clockwise loop into the scope, but because I haven't brought the scope upright, it hasn't gone into play. Do you know what I'm saying? So clockwise torque into the scope. As soon as I bring the scope upright, it will come into play. Come back. Clean your lens. and draw back. Now you can see what it wants to do, which is go forward. The scope itself. Yeah? And now draw back. Again. Now go forward. All the time it's forward and back nice and steady. Once you get round this bend here, so we're just there, clean the lens, anti-clockwise now, so we now take this back out. And back in. How's he doing now? Alright, where's he go? Ah, it's a bear. Yeah. Roll that way, my friend, just that way. Just a little bit further. See it, push the scope forward. Just that way a little bit further, my friend. That's brilliant. So that's instead of putting abdominal pressure on. Now stiffness just to take it back. What's he say? How much is he? A lot? Is that your watch? Have you seen his watch? You've seen his watch. Good watch.
Mobile.
Mobile. So it's SIM free. So I can put any SIM from any network.
Yeah. Samsung is also made this.
Samsung?
Yeah. This is Berlin. I purchased from the UAE airport.
Just anywhere in Dubai?
You can buy, I think that will be available. You can just say the smartwatch.
And is it reliable?
Somewhat. Not as much as the mobile.
Okay.
Cell phone.
Have we got some wash, my friend?
Oh, sir. Okay, what?
Sir. Yes. So what we were doing, we had a lot of looping in the sigmoid, and I was just concerned because of his inflammatory bowel.
Yeah.
So ready? Excellent.
Okay.
Everyone's quiet. Hey, why are people so quiet? Why are people so quiet? Quiet.
चुप क्यों हो सारे? बात करो बॉस के साथ. Hey, Mr. Talk.
You're very quiet. All you did last night was eat.
Yes.
There we go. In. Okay. Happy? Now, my friend. Listen, what's her name? I went to say Lollipop. I didn't let your secret go. I'll tell him now. Yeah, do right side, left side rectum, please. Right. So take some biopsies, my friend. 3 pots. Right side, left side rectum. Stop. You want a couple of samples from here? Stop. A couple of samples from here. So, proctitis, all I'm going to do is just do a couple of samples from the right side just to see if you show anything on the microscope. They won't. The ones on the left side and then... Yes, please. Yeah, 2 from the right, 2 from ascending. No, just stop. Stop. Yeah, stop. Let go.
Sir, रुक जाओ.
Rujo.
रुक जाओ.
Rujo.
Stop.
Rujo.
रुक जाओ. रुक जाओ.
Root Jow.
Yes.
Yeah.
Bloody Root Jow.
Stop.
Root Jow.
Stop. रुक जाओ.
Yeah.
Sit down. Listen. Sit down. बैठ जाओ. 3 बार रहेंगे सर, right left.
You're on tape. You're going to set me up one day, I can see it coming.
I will teach you Urdu.
Yeah, I can see that you'd lead me astray. You would. Air. Just air. Let go. Let go. That's it. A bit of air. That's it. That's good. Now you can biopsy. So. No, you haven't biopsied. Air. This time. Let go. Good. Now biopsy. Too much. Just touch. That's it. Just touch. Go on. Now that's enough. Advance again. Go on. That's enough. That's it. Pull.
Pull.
Pull. Are the biopsies here, are they charged by the pot or charged by the patient?
We get the money for vaccines.
So, but is it per pot, or so if you have 3 separate pots, is that 3 separate prices?
No,
तीनों की अलग जाएगी.
तो एक ही इसमें होता है ना.
टोटल अमाउंट तो टोटल
Is
होगा
it-
लेकिन अलग अलग जाती है.
बायोप्सी तो एक ही पैसे लेता है ना वो.
हाँ.
So,
No, it's the same price for 3 pots.
It
Three
doesn't
pot- that's all right
depend on
then.
the, number of pots.
sorry. So 3 pot.
It not depends on the number.
Oh, yeah. Advance. Stop. Pull. Pull. That's it. Continue to take the scope out. Do his job. That's great. Take the scope back. Keep coming back. He's full of air. Suck. Suck. Rima.
Say mother in English.
Ma say.
Ma.
Ma. Mother.
Words Urdu ma.
Ma.
And English word mother.
Okay, keep coming.
Return ma. Return ma. यानी कि return mother.
Return mother.
Return mother. Rima.
Rima.
वहाँ inflammatory area था वहाँ से.
You say inflammatory? All we want is a couple of representative samples, my friend. Keep coming. Keep coming. Keep the lumen in view. That's it. That's it. Brilliant. Keep your lumen in view. A little bit more. That's good. Keep the lumen in view. See? Keep it in view. See how it's easy to keep it in view if you apply the right torque? Yeah? You've got the scope. Keep the lumen in view. Good man. Keep the lumen in view. You've got the scope. See how much, what I'm trying to show you is what torque you need to put on. So you keep, that's good. Keep coming. Take your finger off the blow. My word, man. Take your finger off the blow. I keep watching him. Big wheel back. Just a touch. Now, what you did there was that you sucked down. So you have to keep your finger off the blow and not suck. Little bit of air. Little bit now. That's good. Keep it coming. That's enough. Now you're not touching the air button at all. Just a little bit of air. Just a little bit. See? That's all you need. You don't need a great deal. Now you take a couple of biopsies from here, clean your lens. Clean your lens. Clean your lens. Good man. That's it. That's it. That's it. You don't need to, you know. And there. Okay? No, stay where you are. I've got the scope. You pass the forceps. Go on. Bit of air. Good. That's enough. Come back with the forceps. Come back. Ask him to open.
Open.
That's it. No, close. Pull. Pull. That's it. So if you keep it here, look, so you put it there, it opens up your screen, okay? Keeping it here shuts off your screen, alright? So but for the biopsies, so take one more. Take your finger off the blow. You're filling him so full of gas, it's unreal. Take your finger away from the blow. Slow down. Clean your lens. Away you go, slowly. Right, they're open. They're out, sorry.
Open those. Close these.
That's it, pull. Right, now go back to the rectum. Excellent, come back to the rectum. Keep coming. Keep coming, take your finger away from the blow, that's good. Keep coming. Keep the torque on. Keep the torque on. Keep the torque on. No, you're going the wrong way. That's the way. Big wheel forward. Good. Now it goes back that way. Now it comes back this way. More. See? Now you go, come back. That's good. Pause, clean your lens. Clean your lens. Slight change now. And we're at 16 centimetres, okay? So proctitis, big wheel forward, slowly. Now take a couple of samples and then we're done. So proctitis to 16 centimetres, my friend. Thereafter, macro normal to terminal ileum. And I tend to describe the proctitis. Big wheel forward, don't waggly, take your finger off the blow. Stop waggly.
Can I told to someone to hold the scope?
You could, but no one can. Right, can you see where the forceps are going to come out safely? No. Big wheel back. Good. Don't put any more air in. That's it.
Open. Close. Close.
And that'll do, my friend. We don't need a lot from here. We already know he's got proctitis. So all we're going to do is just come back. Okay? Do not J. Do not J. Because the J will tear the rectum apart. So, sorry, my friend. Good man. Happy?
Yeah.
What's wrong?